Lovely, thank you. So, I'm Steph Keeble, I'm the Director of Birmingham LGBT. Just before I start, I just wanted to put the slide up with the Safe Places approach. So this is the template that's been sent over. So Safe Places approach, you want all our events, workshops and webinars taking place throughout the Pride World Summit Conference to be safe places for everyone to learn, share and grow. The approach that we expect of our hosts and attendees is respect above all. We will respect one another. Empathy, we will acknowledge the feelings, experiences and identities of those around us. Care, we will create non-judgmental caring spaces for people to be authentic. Support, we will listen, empower and support each other. And inclusion, we will include all LGBTQ plus identities and experiences, ensuring that we actively create inclusive spaces for seldom heard people within the community to be heard and seen. In terms of questions, there will be time for a Q&A at the end. You can either wait till the end or put questions in chat and I'll pick them up at the end. So a little bit about us. So Birmingham LGBT is a third sector organisation which delivers a range of services to the LGBTQ plus community and Birmingham and the wider West Midlands. Formed in 2002 as a breakaway from the then Birmingham Pride Festival, so breakaway group who decided that the community needed something 365 days a year, not just at Pride. Originally very grassroots, very small, did things like Are You Being Heard? So talked to the community about what they needed, fed that back to public sector bodies. In 2008, we partnered with the LGBT Consortium for a Capacity Builders grant, and the remit of that grant was to grow Birmingham LGBT. It was Birmingham Pride Community Trust then, and also to support small local LGBTQ plus groups in Birmingham, and there was a consortium worker for the wider West Midlands. Part of what we did as part of that process was some needs assessment, find out what the needs were in the community and what people wanted. And one of the things everybody said was that they wanted a community centre. There wasn't one in the city then, although to share a bit of Birmingham's LGBT history, the first LGBT community centre in the UK was set up in Birmingham in 1976. It lasted 2 years and then closed due to funding. So in 2013, with a grant from Reaching Communities, Big Lottery, and some capital match from Birmingham City Centre, we set up the first LGBT health and wellbeing centre in England and Wales. We opened with the equivalent of 3.5 full-time workers, and we've grown quite significantly since then. So our services currently include a trans inclusion programme, which includes a trans youth group, a trans wellbeing support worker, some trans affirmative counselling, and a trans strategic development worker who can provide training and policy support to the health and social care sector. We have wellbeing support services. We have LGBTQ plus affirmative therapeutic counselling. We also run some wellbeing support groups run by the counsellors and really look at things like self-care and supporting people to manage their own mental health. We have sexual health promotion service in partnership with University Hospital Trust Birmingham, which includes 2 nurse-led clinics a week, and then outside of those hours we can do HIV point of care testing and assisted self-sampling. We have a service that offers support to older people, which includes activities and events, wellbeing support, and then some capacity building support for groups that are volunteer-led, which is set up to support people as they age. We have an arts and events offer, so that includes Shout, Birmingham's Festival of Queer Culture, and we also run LGBT domestic abuse services, They cover the West Midlands. We have 3 specialist culturally competent LGBT IGFAs, and we also have a group work programme, so funded by Comic Relief originally, now funded by BCC. We developed the first group work programme for lesbian, bi and trans women who are survivors of domestic abuse in the UK, and we're now running that programme and looking at updating the modules so we can run the programme for gay, bi and trans men as well. And then finally, we have a substance misuse service. So we have 2 members of staff who work with LGBT people who have issues with substance misuse, and that programme's in partnership with CGL. This is us, for anybody who doesn't know. Quick picture. So I'm here today to talk about mental health in the LGBTQ plus community. So snapshot of the problem, I'm just going to run through a few stats. So LGBT health in Britain, Stonewall 2018, found that half of LGBT people, 52%, said they had experienced depression in the previous year. 1 in 8 LGBT people aged 18 to 24 said they had attempted to take their own life in the previous year. 46% of trans people had thought about taking their own life in the previous year, and 31% of LGBT people who aren't trans said the same. 41% of non-binary people said they had harmed themselves in the previous year, compared to 20% of LBT women and 12% of GBT men. In terms of healthcare, 1 in 8 LGBT people have experienced some form of unequal treatment from healthcare staff because they're LGBT. Almost 1 in 4 LGBT people have witnessed healthcare staff making discriminatory or negative remarks about LGBT people. 1 in 20 LGBT people have been pressured to access services to question or change their sexual orientation when accessing healthcare services. And in 2018, a national government survey of LGBT people who had accessed mental health services in the past year found that 2% had experienced conversion therapy and another 5% had been offered conversion therapy. And I think it's very telling that in 2024, despite the promises, there was nothing about banning conversion therapy in the King's Speech, even though we know the damage it does in terms of people's well-being. So a little bit of the local picture. Research isn't as up to date, but needs assessment carried out by Woods et al. 2011, out and about mapping LGBT lives in Birmingham, find that 30% of the cohort had access support for a mood affective disorder, 20% had access support for anxiety disorders, 20% had attempted to end their life, and 48% had suicidal ideation, 20% were self-harming, 5% reported having an eating disorder. There were high levels of alcohol and recreational drug use, and 40% said they would prefer specialist LGBT mental health services. So pretty horrendous stats. Why does this happen? Why are there such poor mental health outcomes in the LGBT community? So if you start off looking at the process of discrimination, stereotypes are widely held beliefs about certain groups or types of individual based on prior assumptions and cultural depictions. So, for example, all women are bad drivers, all gay men are camp, all gay men are promiscuous. So there are stereotypes about LGBTQ plus people out there, quite often amplified by the media, may come from peers, may come from parents, may come from schools, from religion. And as a result of stereotypes or the process of stereotyping, people will prejudge, or which means to judge before. So they will form an unfavourable opinion or feeling about a person or group of people based on stereotypes. This leads to the development of what we call unconscious bias, which is a prejudice in favour or against one thing, person or group compared with another, usually usually in a way that could be considered unfair. We all have different life experiences, we come from different places, and we will form these opinions, which can then result in people discriminating. So discrimination means to treat less favourably because of who you are or because of certain protected characteristics under the law. So discrimination is to treat less favourably, it's not to treat differently. And then finally, we have institutional discrimination, which is where an organisation's policies and practices favour a dominant group and discriminate against another group or groups. And these become systematically embedded in the structure of the organisation in the form of norms. And probably one of the best definitions of institutional discrimination was when the police owned institutional racism following the Macpherson report into the homicide of Stephen Lawrence. So we've looked at the process of discrimination and what happens. So one of the theories that has been developed to explain poor mental health for LGBTQ people, because LGBTQ people will start the same as everybody else, but it's how they go through the life course and what happens, which will have an impact. So Mayer 2003 argued that the impact of stigma, prejudice and discrimination creates a hostile and stressful social environment that causes mental health problems for LGBTQ people. This model outlines stress processes, including the experience of prejudice and discrimination, expectations of rejection, hiding and concealing, internalised homophobia, biphobia and transphobia, and adaptive coping processes, so like substance misuse or self-harm. It emphasises the impact of institutional discrimination, so external heterosexism and cisgenderism, and growing up in a heteronormative society and its impact on health outcomes for LGBT people. So that's one model. So I've just put this one up, you won't be able to read it. So this is looking at the impact of internalising homophobia. It could be biphobia or transphobia. So what we've got in the first box is suppression of feelings of same-sex attraction, chronic stress, anxiety, immune suppression, adapting a false heterosexual identity, queer bashing, so could be homophobic to other people, people pleasing, failure to take on leadership roles, depression, and then in the box at the bottom we've got self-abuse, including self-harm, eating disorders, substance misuse, and a range of other things which we just looked at some of the stats for. In the second box, the green circle, we've got a partial acceptance of sexual orientation, but with low or negative self-esteem, which can lead to acting out stereotypes, confusion, low self-esteem, low self-worth, isolation, oppression, myths around relationships being unstable, same-sex domestic abuse, and a failure to take on, failure to have intimate relationships, difficult horizontal hostility, which is where, for example, gay men might not like lesbians or lesbian women might not like trans women. So that's sort of dividing communities. And then in the third box, the yellow box, we've got an interruption, which is what we want. So that's positive images, healthy self-acceptance and coming out. And it's an interruption of that process. Internalising homophobia, biphobia or transphobia is a process whereby people take in the messages they're hearing out there. In Gestalt therapy, it's referred to as introjecting, which means you've swallowed it whole. So the messages that belong out there that people hear become part of themselves. And then I've put up another example of this. So on the outside, the very outside, we've got homophobia, transphobia, misogyny, institutional oppression, the media, police brutality, biphobia, religion, inequalities. Then on the next So that's the institutional level. On the next level, we've got hatefulness, discrimination, denial, violence, hate crime, bullying, rejection, slurs, stereotyping. And then we've got somebody who's internalized those messages, and you've got fear, anger, shame, isolation, self-hatred, trauma, depression, guilt, self-loathing, and bitterness. And that's why affirmative therapy is so important, because it enables somebody to look at this and affirm who they are rather than internalize those negative messages that they've heard. And then just moving on. So this is a slide that sums up what heteronormativity looks like, or institutional heterosexualism, that belief that the world is heterosexual and that heterosexuality is the norm. So by definition, other things become pathologized. So we've got two chopsticks and a knife and fork, asking, so which one of you is the fork? And it's really important not to impose heteronormative standards of relationships onto same-sex couples. So a little bit about microaggressions. Microaggressions, Chester M. Pierce first coined the term microaggressions in the 1970s to describe the subtle insults and put-downs that African Americans experience regularly. So a microaggression is defined as a comment or action that subtly and often unconsciously or unintentionally expresses a prejudiced attitude towards a marginalised group. So microaggressions aren't direct hate, which we've touched on with the previous slide. This is quite often subtle and a lack of understanding. And I'm going to show you some examples. So quite often people will be experiencing microaggressions on a daily basis, and that will have an impact on their health and well-being as well. So some examples of microaggressions referring to sexual orientation: assuming all gay men are promiscuous, quite a common assumption in healthcare settings. Assuming it's just a phase, always a really interesting one, this one. It's never assumed that heterosexuality is a phase that young people will grow out of. Talking about sexual preference, because this assumes choice or lifestyle choice. Assuming heterosexuality, so assuming everybody you meet is heterosexual. Making assumptions based on stereotypes. So which one of you is the man? I just showed you that, something that summed that up. God made Adam and Eve, not Adam and Steve, a Judeo-Christian one which people hear a lot. Asking lesbian women who the father is, and assuming young LGBTQ people are too young to have a relationship. Again, links to it's just a phase. This is one I hear a lot. We'll do training and people say, well, oh, I understand what you're saying, but they're only 16 and they want a relationship. And I'll sort of say, don't most 16-year-olds, because there's an assumption it's okay for heterosexual young people to have a relationship, but gay and lesbian or bi young people are too young to make those decisions. And then some for trans people. So example of some microaggressions referring to trans people. So only including binary gender options on forms, misgendering someone intentionally or sometimes not intentionally, asking trans people if they have had surgery or about their genitals. This one always amazes me. We have a trans trainer who probably gets asked in nearly every training session this question, and it's just not something we'd standardly ask people, but people assume that's okay. Refusing to use gender neutral pronouns because it's too hard or it's grammatically incorrect. Telling trans people they are not real men or women, assuming young people don't know their gender identity, telling trans people they look good or pass as a woman, if it was a trans woman, and denying trans and non-binary people's lived experiences and identities. So what's the impact of microaggressions? Microaggressions have a corrosive effect and create an ongoing feeling of being regarded as a second-class citizen, inferior, or even dangerous. Each microaggression on its own can appear minor and trivial, so may not get challenged, but the cumulative effect can be devastating to an individual, but invisible to others who do not attract microaggressions. Known effects of microaggressions are loss of self-esteem, feelings of exhaustion, depression and anxiety, inability to thrive in an environment, and mistrust of peers, staff, and institutions. So just a little bit about how to increase LGBTQ plus cultural competence in mental health care providers. There's a lot of talk about cultural competence. I'll give you a definition in a minute, but the idea of increasing people's cultural competence is so they're more aware of diversity and different communities' needs, and they don't come out with microaggressions, or they don't misgender people, so that people get a better service when they access. So what is cultural competence? It's a combination of knowledge, skills and awareness pertaining to cultural differences and different interpretations across groups. It's the integration of knowledge, skills, attitudes and behaviours that improve cross-cultural communication and interpersonal relationships. It includes an awareness and respect for differences without making assumptions that everyone from a particular background holds the same beliefs and practices. LGBTQ cultural competence recognises the wide range of diversity and intersectionality within the community. So one thing that's important to increase cultural competence is inclusive language. Interestingly, and we're focused on mental health here, but many LGBTQ plus people actually say they'd rather be asked about their sexual orientation in primary care. So when they register with a new GP, to be asked then. For example, it would prevent the embarrassing contraception conversation with the nurse when they ask if you're sexually active and you say yes, and they ask about contraception because they've assumed heterosexuality and you say you don't use it. They then talk to you like you're a bit silly. Then you say my partner's a woman, and then you've got a very embarrassed healthcare provider. Happens regularly. So it's about the use of inclusive language will prevent some of those assumptions. So treating people with dignity and respect is at the heart of a service. Many LGBTQ people report that they are assumed to be heterosexual by healthcare staff. I just gave you an example. That happens regularly, which impacts on the way they interact with the health service and how comfortable they feel using those services. Many trans people are misgendered or met with an awkward lack of awareness. LGBTQ plus inclusive language ensures everyone is treated with dignity and respect. Inclusive language is a way of acknowledging and respecting the diversity of bodies, genders, and relationships. People express their gender and sexuality in different ways. People can have different biological sex characteristics. Inclusive language ensures we don't leave people out of our conversations or our work. So some tips for using inclusive language. Use gender-neutral language such as everyone instead of ladies and gentlemen, or humankind instead of mankind. Avoid terms that assume certain roles are only performed by a certain gender, e.g. use police officer instead of policeman and cleaning staff instead of cleaning lady. Use terms that include all relationships and avoid assuming heterosexuality is the norm. For example, use partner or spouse instead of boyfriend, girlfriend, husband, wife, and use parent or caregiver instead of mother or father. Include gender-neutral toilets titles in options, e.g. Mr, Mrs, Ms, Mix. Avoid terms that suggest a degree of choice, e.g. using sexual orientation instead of sexual preference, and gender identity instead of lifestyle choice. Don't question or make assumptions about someone's gender, sexuality, or relationship. Accept and respect how people define their gender and sexuality. Employees, including people who identify as trans or gender diverse, must be acknowledged as the gender they identify with. Recognise and respect the difference between sexual orientation and gender identity. For example, don't use straight to mean non-LGBTQ+, as some trans people can identify with a range of sexual orientations, including heterosexuality. So I'm just going to talk a little bit about pronouns. So pronouns are what we use to refer to other people, e.g. he, she, his and hers. When you know a trans person's affirmed gender, use the pronouns that match this gender. If you're unsure, ask them which pronouns they would like you to use. Never assume someone's gender. For example, use gender neutral language when a service user or colleague's gender is unknown. Using correct pronouns is a matter of basic respect. You'll probably find more and more people identifying as non-binary or with a non-binary gender identity. So I've put up some non-binary pronouns. It's increasingly common for non-binary people to use they, them as their pronouns. And MX or mix is sometimes used as a gender neutral title instead of Mr., Ms. or Mrs. So we've got she, her, hers, they, thee, them, theirs, he, them, theirs, him, his, to a range of different pronouns. Sometimes you might say somebody with she, they, or he, they, or he, them, and that means they don't mind either. So it's fine to use both or either. So just a quick note on what to do if you get it wrong. So if you misgender someone or dead name them, so use the name they used to use before they transitioned, or assume they are heterosexual, then you should apologise briefly and move on. Over focusing on the issue can be uncomfortable for the person. Don't make a scene and try hard to get it right in the future. People make mistakes. It's okay to make mistakes, but try hard to do better next time. So I'm just going to got a few slides up about LGBTQ affirmative practice, so what that would look like and what we mean when we talk about LGBTQ plus affirmative practice. So affirmative practice uses a positive and informed approach to working with LGBTQ plus clients. It celebrates and validates their identities as well as acknowledging the stigma and obstacles that these clients may face. When we talk about LGBTQ plus affirmative therapy, it's a therapeutic approach that validates and advocates for the needs of sexual and gender minority individuals. So it's quite often LGBTQ affirmative therapists can come from a range of different clinical backgrounds. All of the staff we currently employ are client-centred, but it's an approach that validates and advocates for people who are LGBTQ plus. Affirmative therapy involves an awareness of societal challenges like stigma and bias, which can result in stress, anxiety, and depression, and helps clients process and cope with those challenges, as well as mental health challenges not directly related to gender and sexual orientation. So it will recognise the impact of stigma discrimination. It will also work with people who may have levels of internalised homophobia, biphobia and transphobia. It will work with shame and trauma. But of course, LGBTQ people could go into the therapy room with a whole range of other issues, problems at work, problems at home, domestic abuse, alongside those. So it looks at all of those issues that are presented. So a few tips on inclusive practice for people. So if you're working with LGBTQ plus people during intake and assessment, ask about sexual orientation, gender identity and dysphoria, preferred pronoun use, and what the client calls their significant other, if there is one. So when you're assessing, ask those questions. In LGBTQ plus affirmative therapy, integration and acceptance are the keys to healing. This means helping LGBTQ individuals to feel more comfortable with who they are and what they truly desire. So you may have people coming into therapy who are really struggling with who they are, and it's about working with that in an affirmative way. It's really important that the therapist or the worker doesn't do any more damage. So it's important that they don't use microaggressions, for example. I talked a little bit about those earlier. Lots of LGBTQ people, when they go into therapy, have negative experiences, which can range from anything from being told that, you know, they need to find an LGBTQ therapist through to being told to go home and pray. We've had to unpick quite a lot of damage that's been done to people from mainstream providers in the past. So as part of therapy, it's important to educate LGBTQ clients about heterosexism, homophobia, biphobia, transphobia, and the ways in which these biases can manifest in both the external world and the client's internal self-evaluation. So how that can impact on them, how the messages they hear externally can impact on them, and look at some of the impact of systemic trauma that can occur from institutional discrimination. So some tips continued. So as part of therapy, educate LGBTQ clients about the ways in which shame forms and prevents them from living fully and happily. It's really interesting. I was speaking to somebody recently about our counselling service, and they were asking if we run IAP, which is what's normally commissioned locally, well, not just locally, which is very much cognitive behavioural focused. And we don't, because 6 sessions probably wouldn't touch most of our clients, because if you've got people who have internalized shame, that can take quite a lot of unpicking. So people tend to need longer time in talking therapy, and they need an affirmative approach. So as part of therapy, explore self-discovery and coming out processes, including both positive and negative, external and internal reactions. And I'd just like to highlight there that coming out for LGBTQ people isn't a one-off event. People don't come out once. They come out every day, all of the time, in a world that assumes heterosexuality and cisgenderism. It's a constant process, which in itself can be tiring. So looking at the impact of that, but also looking at how that can be positive, because what we know, and I haven't put those stats up here, but when people are themselves, when people are able to be the whole of themselves, they're more functioning, they do better at work, they do better at home. So actually being able to affirm yourself and accept who you are is really important for LGBTQ people as they pass through the life stages. So also recognise the way in which the media, religion, popular culture both affirm and denigrate LGBTQ existence, and be willing to discuss this in therapy. It can be really useful in therapy with LGBTQ plus clients to look at positive role modelling. There are more positive images of LGBTQ people now. There are also negative ones, but you will be able to see role models or images in the media that people can focus on. And make sure practice is trauma informed. It's really important that people come at this from a trauma informed approach that also recognises the impact of systemic trauma, that institutional discrimination, and how this has impacted on the lives of many LGBTQ people. The other thing I just wanted to say on that is I think it's also really important that therapists and practitioners make sure that they're LGBTQ culturally competent as part of their training. If they're not, they need to get additional training. It's not the responsibility of the client to educate them. Trans people in particular, whether that's in therapy, whether that's when they go to their GP, find that medical practitioners are expecting them to educate them about gender dysphoria or their transition. And actually there's a power imbalance. It's not for the client who's coming to you in distress to teach you. It's really important that practitioners make sure they have ongoing personal development and they can meet the needs of all clients, including LGBTQ clients. So I'm going to stop there because I've talked to you for quite a while, and I'm happy to take any questions or comments. I'll stop the share.